Hi and welcome back to another video of Medic Notes. This video is on Kawasaki disease. Kawasaki disease is a vasculitis of unknown etiology that is characterized by multi-system involvement and inflammation of small to medium-sized arteries, with resulting aneurysm formation. KD is the second most common vasculitis of childhood. It is more common in children of Asian descent. It has been described in variable frequency in all parts of the world. The highest frequency is in Japan. KD most commonly occurs in children younger than 5 years of age, with a peak between 2 and 3 years, and is rare in children older than 7 years. The incidence in the United States is approximately 6 per 100,000 children who are younger than 5 years of age. A seasonal variability has been described with a peak between February and May, but the disease occurs throughout the year. The clinical course of KD can be divided into 3 phases, each with its own unique manifestations. Aneurysmal involvement of the coronary arteries is the most important manifestation of KD. The 3 main phases are acute, subacute, and convalescent phase. The acute phase of KD, which lasts 1 to 2 weeks, is marked by sudden onset of a high, hectic fever without an apparent source. The onset of fever is followed by conjunctival erythema, mucosal changes, including dry cracked lips and a strawberry tongue, cervical lymphadenopathy, and swelling of the hands and feet. Conjunctivitis is bilateral, bulbar, and non-suppurative. Cervical lymphadenopathy is found in 70% of children, and should be greater than 1.5 cm in diameter for the purposes of diagnosis. A rash, which can vary in appearance, occurs in 80% of children with KD, and may be particularly accentuated in the inguinal area and on the chest. Extreme irritability is prominent, especially in infants. Abdominal pain and high drops of the gallbladder, cerebrospinal fluid pleocytosis, sterile pyorrhea, and arthritis, particularly of medium-sized to large joints, may occur. Carditis in the acute phase may be manifested by tachycardia, shortness of breath, or overt heart failure. Giant coronary artery aneurysms, which are rare but occur most commonly in very young children, can appear during this phase. Next is subacute phase. The subacute phase, which lasts until about the 4th week, is characterized by gradual resolution of fever if untreated, and other symptoms. Desquamation of the skin, particularly of the fingers and toes, appears at this point. The platelet count, previously normal or slightly depressed, increases to a significant degree. This phase heralds the onset of coronary artery aneurysms, which may also appear in the convalescent phase, and pose the highest risk of morbidity and mortality. Risk factors for development of coronary artery aneurysms include prolonged fever, prolonged elevation of inflammatory parameters such as the ESR, age younger than 1 year or older than 6 years, poor response to therapy, and male gender. The 3rd phase is the convalescent phase. The convalescent phase begins with the disappearance of clinical symptoms, and continues until the ESR returns to normal, usually 6 to 8 weeks after the onset of illness. Bowlines of the fingernails may appear during this phase. For investigations, it is particularly important to exclude other causes of fever, notably infection. It is appropriate to obtain blood and urine cultures, and to perform a chest X-ray. In the acute phase, inflammatory parameters are elevated, including white blood cell count, C-reactive protein, and the ESR, which can be profoundly elevated. Platelet counts may be inappropriately low or normal. A lumbar puncture, if performed to exclude infection, may reveal pleocytosis. Tests of hepatobiliary function may be abnormal. Greatly elevated platelet counts develop during the subacute phase. The development of coronary artery aneurysms is monitored by performing 2D echocardiograms. Usually during the acute phase, at 2 to 3 weeks, and again at 6 to 8 weeks. More frequent echocardiograms, and potentially, coronary angiography are indicated for patients who develop coronary artery abnormalities. This is the diagnostic criteria for Kawasaki disease. The child must have fever more than 5 days, associated with at least 4 out of 5 criterias, which are bilateral non-suppurative conjunctivitis, changes in mucous membranes of upper respiratory tract, dry fissured lips, strawberry tongue, changes in extremities like peripheral erythema or edema, periungual desquamation, polymorphous rash, and also cervical lymphadenopathy. The diagnosis of incomplete or atypical KD, which occurs more commonly in infants, is made when fever is present for at least 5 days, even if only 2 or 3 clinical criteria are present, particularly in the presence of coronary artery aneurysms. The diagnosis of KD should be considered in infants younger than 6 months of age with fever for at least 7 days, even if no other criteria are present. Because many of the manifestations of KD are found in other illnesses, many diagnoses must be considered and excluded before the diagnosis of KD can be established. These are the differential diagnosis of Kawasaki disease: scarlet fever, EBV or adenovirus infection, meningococcemia, measles or rubella, and many others. For treatment, intravenous immunoglobulin, IVIG is the mainstay of therapy for KD, although the mechanism of action is unknown. A single dose of IVIG, 2 gram per kilogram over 12 hours, usually results in rapid defervescence and resolution of clinical illness in most patients. And more important, reduces the incidence of coronary artery aneurysms. Aspirin is initially given in anti-inflammatory doses, 80 to 100 mg per kilogram per day, divided every 6 hours, in the acute phase. Once the fever resolves, aspirin is reduced to antithrombotic doses, which is 3 to 5 mg per kilogram per day as a single dose, and given through the subacute and convalescent phases, usually for 6 to 8 weeks, until follow-up echocardiography documents the absence or resolution of coronary artery aneurysms. Up to 10% of children with KD initially fail to respond satisfactorily to IVIG therapy. Most of these patients respond to retreatment with IVIG, but an alternative preparation of IVIG may be required. Corticosteroids or infliximab are used less frequently in KD, as opposed to other vasculitides, but may have a role during the acute phase if active carditis is apparent, or for children with persistent fever after 2 doses of IVIG. These are some complications of Kawasaki disease, including coronary artery thrombosis, artery aneurysms, myocardial infarction, myopericarditis, heart failure, hydrops of gallbladder, aseptic meningitis, arthritis, sterile pyorrhea, pancreatitis and others. For its prognosis, IVIG reduces the prevalence of coronary artery disease from 20% to 25% in children treated with aspirin alone, to 2 to 4% in children treated with IVIG and aspirin. Prolonged inflammation greater than 10 days puts the patient at greater risk for developing coronary artery aneurysms. Other than the risk of persistent coronary artery aneurysms, KD has an excellent prognosis. That's all for this video. Thank you.